Okay, let's do narcotics. Okay, let me get on my soapbox for just a second about narcotics. So back in the 1900s, we had this thing called the prohibition of alcohol, and they took all the alcohol off the market, and they said, you know, it's bad for you, it's causing so many problems, let's just get rid of it. And what happened was is they took all the alcohol off the market, and it actually got worse because then people were like in their backyards, like mixing up their own shine, right? Had a bunch of people who got moonshine blindness, and anyways, it was bad for business. Well, about 2 years ago, maybe a little bit longer than that, they decided that we were going to crack down on the amount of narcotics, that the narcotics are the problem, and that we really need to just get all the narcotics off the market. It's not worked real well. Just got back from a conference. Conference basically said, kind of dreamed up what some people said. They're like, hey, you know what? If you take all the narcotics and you make them harder to get, you're going to decrease the narcotic usage, but you're going to kill a lot more people because they're going to try to get their narcotics from someplace else. Absolutely true. So now we've created a new problem. So narcotic usage in the state of Texas is down, but narcotic deaths are actually up. And that's because people are going over to street drugs, or they're getting some narcotics that have been manufactured outside the United States and are not being regulated. So, narcotics. All right. In order to talk about narcotics, we've got to talk about receptors. Let's go to those next. So with receptors, one of the things that we look at is our pain receptors. We have mu, kappa, and delta. No, it's not a sorority. Those are your pain receptors. With the mu receptors, whenever we agonize them or we make them work for us, this is kind of the things that we get. You can see the left side versus the right side here. If we had a choice between activating mu receptors versus activating kappa receptors, honest to goodness, we would just activate kappa because, you know, mu gets into some kind of dumb things. You know, both of them have sedation, but like mu receptors, whenever we activate those, we get respiratory depression. We get physical dependence, we get GI motility issues. So if we could just activate kappa, but our drugs just aren't quite like they're quite yet. So we're going to get there eventually, and we'll have some great drugs in order to control pain. But for now, we're not quite there yet. Right now, we have drugs that activate 3 different receptors. We have things called an opioid agonist, opioid antagonist, and then something called a mixed opioid agonist-antagonist kind of guy. So the opioid agonist is probably the one that I feel like everyone has at least heard of morphine. They activate both the mu and the kappa, so we're going to get both of those reactions, which could cause a problem in the long run. But with the right dosage, good nursing care, we can avoid a lot of that. The opioid antagonist, this is going to help actually block both mu and kappa, and this is going to be our drug Narcan, naloxone, which is going to be our reversal agent or our antidote for an opioids. Our mixed opioid agonist kind of guys, they occupy one receptor and block the other. So it's kind of nice that you have that, but I'll tell you that these drugs aren't as in favor today as they were 10 years ago. And we'll talk a little bit more about those when we get there. So what we like to say about patients who are taking their narcotics is that they can't breathe, they can't pee, they can't poop, they can't see, they can't stand, can't hold anything down, can't cough anything up, and my gallbladder is killing me. Can I please have some more? That's all of the signs and symptoms that could come with narcotics. So I'll say it again. Can't breathe, pee, poop, see, can't stand, can't hold anything down, can't cough anything up, and my gallbladder's killing me. Can I please have some more? That's all the signs and symptoms of someone who is taking narcotics. I like this little meme here. You know, it's like, oh, you know, it can also cause anxiety or death, addiction. I mean, hey, whatever. It's just a narcotic. It's a big deal. It's a narcotic. We have a couple of different patient population groups that we really need to think really closely and hard about before we start doling out narcotics. Of course, in our pediatric population, everything's not completely formed yet, and kids are pretty freaking resilient. Like, their need for pain medication is way less than us as adults. Geriatric patients, again, we got to be careful. How's their liver? How are their kidneys functioning? What's going to happen if I give this to them? Am I going to kill them? Like, there's true legit questions here. My head injury patients. If I slow down a patient who has a head injury and they start retaining their CO2, then I can actually make their head injury actually extend worse into the tissues because they're not going to be getting oxygen to the tissues like they need to be. IBS is irritable bowel syndrome. There's two different types. There's the kind that has diarrhea, and there's the kind that has constipation. So the patients who have diarrhea, we have a drug for that that's got a little bit of a narcotic in it called Lomotil. Actually, over-the-counter Imodium's got a little bit of a narcotic in it, and it will slow them down so that they don't have diarrhea. But if you have a patient who has IBS and it's constipation, the constipation type, and you give them a bunch of narcotics, you're going to make the problem worse. Okay, liver impairment. If their liver's not going to be able to metabolize the drug, it's going to build up to toxic levels, and the patient's going to get sicker. Of course, hypotension. If the patient has a low blood pressure, you don't want to make it even lower. All right. Benign prostatic hypertrophy. Again, this is what causes the prostate's really, really big, and it has a really hard time. The bladder has a really hard time trying to get around that prostate so that the patient can pee. This is going to make the problem even worse. Pregnancy. Pregnancy, and specifically during labor and delivery. There's a certain time whenever it's just no longer appropriate during the laboring process to give a mama any kind of narcotics because we have to be worried that whatever mama's taking is going to go to the baby. If we give mama medicine too soon, close to delivery, the baby will come out and be all floppy and won't be breathing right. So you have to make sure that the baby's got to have enough time to metabolize off that medication. Chronic lung problems. This medication is going to decrease the need to breathe, okay? So if a patient has chronic lung problems, we don't want to make their chronic lung problems worse. So you got to be real careful. And then, of course, renal impairment. If they can't excrete the medicine, we need to decrease the dosage, maybe decrease the frequency of that so that the body has time to process through. Now then, here's the except. All of these are good things to remember for normal everyday patients, okay? But if your patient is dying, they're in a hospice situation, they have signed their do not resuscitate order, we don't care about any of this, okay? At that point, it is medication for comfort, not medication. We're not going to be worried so much about the side effects of it. We're definitely not going to give them enough medication to kill them and make them stop breathing. We're going to give them enough medication to feel like that they're not struggling to breathe, struggling to live in that moment, okay? So just to let you know that this is for normal patients. There is an except. The except is hospice patients, okay? Therapeutic actions, our overall goal is we want to relieve the pain. We may want to induce a little drowsiness because when you're hurting a whole bunch, sometimes if we can induce a little drowsiness, help you not to think about it quite so much, reduce your anxiety, we can get that pain to kind of ease and ebb away. Of course, our risks are always the development of tolerance and the development of physical dependence. If we were going to look at any one drug as being like our ultimate, like, that's our boy, it would be morphine. Morphine got its name from the Roman god Morpheus. He was the Greek god of dreams. And so what they found is that the poppy plant, which you can see down here in the right-hand corner, was actually, they extracted the syrup, like it's lack of a better term, from the plant, and then that's where they got the derivative morphine from. Morphine can be the poppy seed gum, I don't know what to call it, that comes out of that little bulb thing there, is used to make morphine, heroin, codeine. It all is extracted from the same plant. We don't, in the United States, have a rule against growing these, but if you're caught with them, they pull them up. So, and especially when they find them in large fields, not the kind of plant that you should be growing. So they tried to make it illegal here in the US, and apparently that there's a thing, like it's not illegal. I just think that's funny. I'm like, okay. Other medications on here, they'll go down in effectiveness, but again, morphine, he's our guy. Go Morpheus. So a few little things here about morphine. Morphine is a pretty strong opioid. We have lots of different ways in which we can administer that medication. We always want to give it in small doses and then titrate to effect. I'll tell you that most humans, we start with 2 to 4 milligrams and we go up from there. The general rule when we're pushing this medication is it doesn't have to be diluted, but it does need to be given slowly, and you do need to give it in a nice controlled environment. That's where you're going to have a pulse ox, and you're going to have a way of monitoring their blood pressure, checking their pulse, making sure that they're breathing. This is not a medication that you'd push and then run on to the next patient. Instead, you're going to be there with this patient for 10 to 15 minutes, making sure that they're not having any kind of an adverse reaction. Again, this medication does require special licensures in order to be able to get it, and special prescription privileges. So you can't just like, the physician can't just like pop in and be like, yeah, I'll give you a refill on your morphine. It's not how it works. In the wide world of hospice, there's always exceptions, and they definitely have ways of working around morphine and prescriptions and stuff like that. Another medication called fentanyl. Fentanyl is a very strong opioid. In fact, it's so strong, it is actually given in micrograms instead of milligrams. It is chemically designed morphine, and because of that, it's a lot more potent than morphine. So we give it very small doses. So literally, I would give someone 2 to 4 milligrams of morphine. I would give someone 1/2 to 1 milligram of this in a normal dosage. Slow IV push, but the great news about this one is that it doesn't last as long as the morphine. So we used to get in trouble back in the day. Whenever a patient would come into the emergency department and be having horrible pain, we would go in and give morphine. When we gave them morphine, then the next doctor would come in to assess the patient, and he couldn't figure out what the heck was wrong because we'd given them morphine and they were feeling good. So the drug manufacturers heard the cries of the poor providers and made this drug fentanyl. So the great news is it has a very short half-life. It only lasts for about 30 to 60 minutes. Comes in lots of different forms. It comes in an IV, of course, and then it also comes in a transdermal patch that you take off and change once every 3 to 4 days. And then it also comes in lozenges, and they can even put it on a lollipop for small children if they need to have some fentanyl. At low doses, it's for pain control, and at higher doses, it would actually be used for anesthesia. Like, you can put someone to sleep with fentanyl. We typically will use fentanyl in like our ICU as one of our critical care medications. We'll put it in a patient-controlled analgesia pump, and then we'll use that medication to help induce sleep, like if a patient's like on a ventilator. Mepridine. Mepridine used to be is an oldie but a goodie. It's kind of lost a lot of favor with different groups because we found out that it can accumulate to toxic accumulations in fat cells. So the medication, you give it, and then instead of like being in the system and doing what it's supposed to do, it like goes and like, hey, fat, and hangs out with fat. Well, then all of a sudden, the fat cells are real unpredictable, and then all of a sudden they're just like, okay, that's it, you're gone. And they throw the mepridine out of the house. Well, then the mepridine starts acting again when we thought it should be over. So it also doesn't play well with other drugs. Okay, it's a whole protein binding bus thingy again. So again, not as popular as it used to be, but I'll tell you, people still ask for it by name. They're like, hey, can I get some Demerol? So the other medication that I did not put on here for you guys is one called hydromorphone, also known as Dilaudid. I will tell you that a lot of these medications that we've just spoken about have got some very special and specific instructions from your hospital system about administration, things that you will assess while you're given this medication, and things you will do while you're given this medication. So please make sure you know your hospital policy about administering narcotics. There's some narcotics that you absolutely cannot give on an unmonitored floor. So if you don't have a telemetry box and you don't have someone who's constantly watching that heart rate, you can't administer it. So figuring out what your hospital policy is whenever you go to work will be a big deal for you. So a couple of things about narcotics that I think is important for us just to kind of like take a time out and let's talk about. Narcotics are on a strict count. So the pharmacy knows that they dispensed 10 pills to the unit. You count 10 pills with the little pharmacist that comes to stock your Diabold or your medication dispenser system. And then the pharmacy can go back and they can tag and say, okay, 1 of this went to this patient, 2 of this went to that patient, this one was dropped. They can monitor back and forth and they can see all of that information in the system. So whenever your documentation of what you did in the patient's record and what you pulled from the Diabold and what the pharmacy dispensed, when all 3 of those are matchy, 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 we're good, good, good. But if something comes back as an unmatch, they're going to start digging. So very important that you keep your count correct. Okay, whatever you pull is what you're going to be ready to use. Don't pull something pocket it, thinking, oh, I'll get to it, and then get home at 7 o'clock at night and realize that it's still in your pocket. That's a bad day at the office. That's a write-up, okay? No fun. One of my big things is that I want you to get in the habit of doing is witness the waste at the time of the dispense. So I'll tell you that we used to not do this, and so your preceptor or future nurses may not do this, but you're smarter than them in this regard. You're not going to be like them. So what would happen is back in the old day, we would get a syringe and it would have, let's say, 10 milligrams of morphine in it. But the physician had only ordered me to dispense 2 milligrams of morphine. And sometimes they'd write me a prescription or an order that would say, give 2 milligrams of morphine every 5 minutes for a total dose of 10 milligrams. So I would keep that morphine and I would literally tape it to my badge, and then I'd go in and check on the patient and I could give them 2 milligrams, and if everything was okay, I'd come back, 10 minutes later and they're like, yeah, I'm still hurting. We do 2 more milligrams. And so we kept doing like that until we got their pain under control. Now we don't do that, okay? I don't care who they say they are, don't do it, all right? You dispense and you witness at the waste at the time of the dispense. So now if the physician ordered me 4 milligrams of morphine on Sunday to give to a patient, so I'm going to pull up the 4 milligrams, I'm going to get into the dye bowl, let it drop, I'm going to have it in its original syringe, I'm going to knock on my glass wall because I'm in a glass building. I'm going to be like, hey, get in here. And then we're going to pull up all 4 milligrams, okay, in my syringe. And then I'm going to waste what I don't need. And now I just have the dose that I need in my syringe. And then I'm going to tape, I usually take my syringe and the bottle that I dispense from, I tape them together. So when I go to see the patient, I can be like, okay, this is your morphine. That way I can show it to them. Otherwise, there's some patients that are just kind of, I don't know, suspicious about everything we do. So I'm going to witness it at the time of dispense. I'm not going to wait and do it later. Whatever you do, don't put it in your pocket. One day last week, I know, dumb nurse moment, I put my syringe of my morphine in the IV thing, and then all of a sudden the plunger came out of the back of the IV, and all the morphine and all the saline was just poured on the floor like a faucet. I was like, oh my gosh! I swear it's never happened to me. Only witness what you saw. As you get into nursing, you're going to find out that not everyone is honest. I know it's hard to believe, but in nursing, there are some dishonest people. So if someone pulls up a drug and says, oh, hey, I only used such and such down there, can you come and witness my waste? The answer is no. As a new nurse, you don't do that. Tell them to call the charge nurse. You don't want to be caught between a rock and a hard place, and that's a very uncomfortable position to put you in. So again, if you don't know the person very well, and again, it's just a horrible practice to get into, you witness before you walk out of that room, okay? Always be ready to be accountable. Always be ready to take a drug screen, no matter what, okay? Your responsibility in that is that you don't ever need to take a medication that you don't have a prescription for, okay? Had a good friend of mine, was going for a job and needed to take a drug screen, took a drug screen, didn't think twice about it, and drug screen came back positive. And they're like, no problem, give us your prescription. We just want to make sure that everything's cool. They didn't have a prescription for the medication they took. It was their mom, something that popped positive in a drug screen. Okay, person needed the medicine because had whatever was going on, but popped positive on a drug screen for that narcotic. So don't do it. Okay, don't take a medicine unless you have a prescription for it. PCAs, I kind of alluded to these a little bit ago. So PCA, sorry, everything's itching all of a sudden. Patient-controlled analgesia. It's a small little IV pump that's really, really smart. This IV pump is locked down where the patient will have a narcotic that'll be inside of a lockbox, and we will give them a basal rate of medication. They'll get a little bit of that medicine every so often, so we get so many milligrams an hour. Then we give them a little button on a wire. We put it in their hand. We're like, if you have a breakthrough in pain, I want you to press your button. Only you can press your button. No, ma'am, you can't press his button. Only you can press your button, sir. Okay? So what we found with this one is that the patients actually use less pain medication because they're in control. They're not waiting on nursing to try to hurry up and get there. And so very important, and that anesthesiology and nursing tend to work together to make this process happen. At the end of the day, that pump is cleared and re-zeroed at the end of every shift. So you can see exactly how much the patient got every hour, how much they took on their doses, and then how much was wasted whenever we change out the cartridges. And again, everything should be matchy, matchy, matchy. All right. Again, you'll have a hospital policy that will guide you on PCA pumps, and sometimes they'll even require you to go through a PCA class, which is super helpful. Other medications that we give that are narcotics, codeine, hydrocodone, oxycodone. These medications can be combined with acetaminophen, ibuprofen, or aspirin, and it helps the medications to work even better. In a randomized double-blind control study, they did all these tests with these patients and like only gave this group hydrocodone, and gave this group Tylenol or an ibuprofen alternating doses back and forth. You know what they found? Sorry, I'll tell you what they found. What they found is that the patients who received Tylenol and Motrin alternating doses had as effective pain control as those patients who just received codeine, hydrocodone, or oxycodone. So it goes to prove to you that if we treated pain a little bit more like we treat fever, every 4 hours routinely, regularly, that maybe we could get a little bit further with just our over-the-counter medications. Again, be careful with these medications. They're very commonly are prescribed with those over-the-counter ones. So I have to tell my patients, like, look, you're getting Tylenol with codeine today. Do not take any other products that have Tylenol in them because this medication has Tylenol with it. So again, making sure they understand those hidden dangers of where those medicines may be lurking. These are our agonists, antagonists, and you would think that these medications would be a little bit more popular, but they're actually not. We don't see these quite as often. I will say that probably 20 years ago, there was a lot of people on these medications and they were highly abused. So we don't see them as frequently as you would think. You would think with the antagonist to mu and the agonist to kappa that this would be like the best, but it's not. Saw a lot of that. These patients too, if you have a patient who was on an opioid and then you put them on this one, you can actually cause them to have withdrawal symptoms. Kind of crazy, but you will see it and not a very comfortable place for a patient to be in. So again, as we're getting ready to use those opioids, I go into my patient's room. I want to assess what their pain is. We're going to use a little pain scale. I love the one that's got the little smiley faces on it. I think everyone can understand that one. We have other instruments and tools as nurses, depending upon your hospital that you're working for, as to how they want their pain to be registered. There's something called a FLAC score, and then there's another one that I can't think of the name of right now. But it'll come up in your documentation system about how they want you to do it. If your hospital or whatever organization you're working for doesn't have one and you're medicating for someone for pain, the question is, on a scale of 1 to 10, with 10 being the worst pain you've ever experienced and 0 being no pain, where's your pain level at right now? And then I write patient reports, and I write the number and I circle it, okay? And then underneath that, I will document patient sitting up in bed, eating Cheetos, talking on phone, no apparent distress, no pain indicators. And I love to put in there what their vital signs are, because patients who have pain, who are not on medications that are going to control their pulse rate or control their heart rate, you're going to see a huge spike in their blood pressure and their pulse when they're in pain, okay? You need to educate your patient about for effective side effect management. If we're going to give them opioids, we need to let them know this medication may make you dizzy. It may make you want to fall down. I need to make sure that whenever you're getting up to go to the restroom, that someone is present with you. Please call me. Okay, that's the inpatient setting. At home, there needs to be someone with them whenever they're going to be taking their opioids. We need to think about those things that are also going to happen, like long-term problems of constipation. If we just have our patients take a $1.97 stool softener, not the stool softener with the laxative, just the stool softener, people, it'll help to prevent constipation from happening. And then, of course, if we can get them to drink water and eat extra fruits and vegetables, it'll keep things moving along. The other thing we need to plan for is if we're going to send a patient home on opioids, we want to make sure that they're prepared in case of an overdose, especially these patients who have a high tolerance for the medications. Had a sweet lady that I knew for a long time. She was taking multiple different medications for anxiety, depression, and got injured and needed to take some narcotics. And what happened was that she kept telling the nurses, I'm hurting, I'm hurting, I'm hurting, I'm hurting. So I don't know if she was just hurting from the pain or if just the stuff that she was, it just wasn't caught up with her yet. But all of a sudden, everything that they had been giving her all day long finally caught up with her, and she actually went into respiratory depression because it's kind of like it wasn't working. Oh my gosh, now it's going to work. And it wasn't anything funky that they were giving her. It was just like, I think it was fentanyl. So, but it all kind of caught up with her at one time. So again, when we're sending these patients home on opioids, we need to prepare patients and families for the potential for an overdose. So this is our opioid antagonist. Narcan is our reversal agent. You can actually purchase this over the counter now at your favorite pharmacy, Walgreens, Walmart, and CVS. You don't have to have a prescription for it. You just have to get it from the pharmacist. So what you're going to see here is the cost though. So a vial of naloxone is only 30 bucks. Okay, but that means that someone has to be smart enough to be able to put the needle in the syringe and drop the appropriate amount and then stick the person. A pre-filled syringe is like 50 bucks, but then the easiest form, which is the nasal spray, literally shove it with the nose and spray, it's $130. Geez Louise. The people that I know that need an opioid antagonist don't have $30. They barely have $130. They don't have $130. Well, not that they're willing to spend on their Narcan. They're more than willing to spend it on drugs, but that's neither here nor there. So again, the people who need it can't actually afford it. But on the eCampus course or on our course today, you'll be able to find there's a PDF document. That's all you have to do is you have to have that PDF document and take it and hand it to the pharmacist, and they will dispense the Narcan to you at cost. The other thing we want to know before a patient starts to receive opioids is we really want to know, is this patient at risk? So is this patient at risk for development of a physical dependence if we give them an opioid? So this is the risk factors for substance abuse. Again, a very simple little screening tool that can be done. Typically nursing is one of the ones that does that. In my social history, I always ask about a couple of things. Do you drink alcohol? Yes or no? How often do you drink alcohol? Do you use recreational drugs? Marijuana, cocaine? No. Did you ever use those in your past? Do you smoke? Yes or no? How often do you smoke? Those types of things can let you know like what kind of state the patient's in. Again, I always ask in my physical assessment and my primary history taking as a nurse, I ask things like, okay, have you ever been sexually assaulted? Are you a victim of domestic violence? Yes, yes. Okay. Do you have any kind of psychiatric problem, mental health diseases, depression, anxieties? Yes, yes. And then if they tell me that they've used some illicit substances, I always want to know what age do they start, and then I'll document like onset age use of marijuana at age 15. Okay. And then again, whenever they're using illicit drugs, how are they using them? Okay, important to know because smoking and injecting tend to be higher dose potentials than others. Essentially acting non-opioid. So your book doesn't include this one. I'm like, I got to call these authors saying I have to work on this because this medication is everywhere. We see so much tramadol right now with all of our patients. Now that they're not getting hydrocodone or codeine, they're getting tramadol. So it is an analog of codeine, has a weak agonist activity against the mu. You're going to see it a lot. Has some drug interactions. Technically, it's supposed to block by norepinephrine and serotonin. And so it really shouldn't have a reason to be addicted to it. And so maybe it's just the people that I'm hanging with, but these people all seem like they're a little addicted. And when they don't get the tramadol, they get kind of upset. Okay, so they're trying to do away. People used to get this one and it would just basically be in their medication list and they would take it every single day. Well, we're trying to get away from that, from treating pain every day and instead getting to something a little bit differently. Okay, let's see here. So the nurse has received an order to administer morphine 4 milligrams to a patient with a 10 out of 10. What should the nurse assess before administering the medication? So think it through. I'm going to answer my family because they're all talking about Thanksgiving coming up and holidays. All right, so things that I would do before administering the medication, and hopefully by the time that you get an order for morphine, you've already done this, but a good health history, okay, asking those social type questions. I want pre-vital signs. If the laboratory work has already been drawn and back, I need to look at liver and I need to look at renal. I need to make sure that the patient can understand that, like, once I give you this medication, you're not getting up on your own. I have to be with you. And for goodness sakes, if you're working in like an ambulatory care center or an ER, my golden thing is before I administer a narcotic, whoever's going to be driving them home, they got to be sitting eye to eye with me, because there ain't no way I'm giving someone a narcotic like morphine that lasts for 4 to 6 hours and then have to sit on the patient for 4 to 6 hours and take up a bed. It's not a good day at the office when that happens. This patient needs to understand that this is a narcotic, that when I give it to them, you know, they may not be able to see well, they won't be able to cough well, they may not breathe well, they may develop constipation, they may be nauseated. Like, I need to tell them the side effects, what, you know, got to be reasonable here. And then again, making sure that they understand what's going to happen when I give them the medication. All right. All right, here's the next one. Patient has received the 4 milligrams of morphine about 30 minutes ago. Now what do I need to assess? So number one, I'm going to go back in and I'm going to be, well, probably before 30 minutes, I'm going to be back in there at 15. Be like, hey, so tell me, how are you feeling now? Are you feeling a little bit better? I'm like, yeah, I'm feeling a lot better. Good. What's your pain level on a scale of 1 to 10, 10 being the worst, 0 being none? Are you having any side effects? Okay. I'm going to redo the vital signs, and then if I have any kind of a weird adverse reaction, I'm going to be letting someone know. And like I said, typically when I give morphine with the patient, I'm usually hanging out with them for the first 10 to 15 minutes. Okay, I'm a pest. I want to know, like, I'm going to give them their morphine and recheck their vital signs and straighten the pillow and change out the trash can. I'm going to do all sorts of stuff for the 10 minutes that I'm in there. It'll take me right at 10 in order to give them that medication. Okay, now what? The same patient now needs to go to the restroom. What does the nurse need to assess before ambulation? So the question becomes, can this patient get up and go to the restroom? And the answer is maybe. Just kind of depends, right? So if I set them up on the side of the bed, the first thing I'm going to do is I'm going to do a dangle test. Okay, so they've been laying down, they got their morphine. We're going to sit up on the side of the bed, and I'm going to say, hey, how you feel? You feeling okay? Okay, good. We're just going to sit here for a minute. You've been laying down, you've had some narcotics. We're not going to boogie. We're just going to sit here, okay? If they have to go now, they have to go now. I gotta go now. The answer is they need a bedpan. Okay, because if I can't assess that they're safe, then we don't go anywhere, because it's real hard to fall in a bed. All right, they can fall when they get out of the bed, but they can't fall in the bed. All right, so sometimes what I'll do is I'll offer a bedpan and see if I can get it done that way. I'll go get a potty chair. That way we don't have as far to go. Again, maybe even offering a pure weight catheter, something like that, in order to help them go to the restroom without getting them up to ambulate. So opioid dependence, I want you to take some time and really define what a physical dependence is. It typically takes 7 days to withdraw from the entire narcotic dosage. Posted a video, it's kind of hard to watch, about a young lady going through opioid withdrawal and what she went through for 7 days. They actually videoed it, so it's pretty horrific to watch, just the pain that she was in. Even though her physical dependence from the medication, when she was finally cleaned out, the psychological dependence after that will last a lifetime. My mom was a smoker, and to this day, she'll tell me, she'll like walk by somewhere and someone's smoking, she's like, I just want to hit. And you know what? I can understand that, because I feel like, you know, if you told me I could never have chocolate again, and every time I walk by someone eating chocolate, I just want to hit, right? We do have programs for patients who have lifelong dependency on opioids. Treatment programs like methadone, Suboxone, those types of drugs continue the opioid dependence, but help to eventually get them to a safer place to where eventually, hopefully, we can get them off of opioids completely. All right, so we got to change gears a little bit, okay? So sometimes if our patients are having issues with pain and inflammation, they can also be having like muscle spasms on top of everything else. So sometimes if we just help to get rid of the muscle spasm or the spasticity that they're experiencing, we can make the pain a lot better. So let's kind of talk through those sort of things. Here's your objectives, and we're moving on. So muscle spasms, they can be from excessive use, they can be from injury, they can be from medications. So again, very uncomfortable top spasms. You can have tonic spasms, you can have clonic spasms. We do a lot of different things to try to prevent muscle spasms from happening. I have 2 boys, both athletes. We do a lot with muscle spasms in our home. We do a lot of like, go lay down, go rest, heat, cold. We're like, okay, go get in the hot bath, throw some Epsom salt in there. We do exercises, massage, we do some physical therapy, we do a lot of neural flossing in order to make it all stop. Don't have access to ultrasound here, but that's a wonderful option to help treat patients who are having frequent muscle spasms. If we can get the muscle spasms to stop, sometimes that will decrease inflammation, decrease the pain, decrease the edema, it makes everything better. We have a couple of options over the counter, black cohosh, castor oil packs, and capsaicin. It's going to all be applied to externally to help prevent muscle spasms. Also, vitamin therapy like vitamin B6, magnesium. Our biggest thing here is we want to minimize their pain, increase their range of motion, and get them back on their feet again. Say it with me. Do not drive or operate heavy machinery while taking this medication. Do not consume alcohol or illicit drugs while you take this drug, because if you do, you're going to crash. Excuse me. Here's our essentially acting muscle relaxants. I will tell you that in this area, you're going to see a lot of cyclobenzaprine. You'll see some methocarbamol, and you'll see some tenazidine. Those medications tend to be given out quite frequently in our community for the control of muscle spasms. Carisoprodol, that medication is a Schedule 4, and it's the only one on there that out of the first couple ones that are actually on there. The carisoprodol it's a really popular drug. Like, it is so popular that before you prescribe it, you actually have to go to a special website for providers, and you have to look up to see where else they've gotten it filled at. That's how special it is. It has a high abuse potential. People really, really like that drug. The other ones I starred here are your clonazepam, diazepam, and lorazepam. So these medications can be used for a couple of different things. They're good skeletal muscle relaxers, but they're also used for seizures, for anxiety. All of those that are starred also have a high abuse potential and require a special prescription or special monitoring of that medication. All these medications can cause drowsiness, a dry mouth, sedation, ataxia, you can't pee, hypotension, bradycardia. The PAMs, the clonazepam, diazepam, and the lorazepam, all 3 of those can actually cause respiratory depression. And I'll tell you, just from being a nurse for 20 years, the carisoprodol will also cause respiratory depression too. So I'm going to disagree with your book. Your book says that baclofen is essentially acting skeletal muscle relaxer. I will tell you that most frequently in this town, you're going to see this medication given for spasticity. Don't see a lot of dantrolene given in the patient populations that I deal with through the emergency department, but that doesn't mean it's not being given. But if we were going to choose one, we would choose baclofen as a kind of a prototype drug for a spasticity drug. I guarantee you, you walk on a nursing unit tomorrow or into a doctor's lounge and say, I wanted to know what drug you give for spasticity. Probably 95% of them would say baclofen, and then a very small portion would say the dantrolene. Again, medication can make them drowsy, can make them feel weak, fatigue, nausea, constipation, urinary retention. Again, helping with the spasticity is a big deal. I had a patient, she's a bilateral amputee, amputated at the hips. So there's nothing to put prosthesis on. She's so amputated that far. And this was a medication that nobody wanted to prescribe for her anymore. That type of a patient needs this medication. She has a spinal cord injury, not an injury, but a spinal cord insult with having both of her legs removed. So that spasticity is a huge issue for her. She takes the medication once, maybe twice a week. Again, not overusing it, just using it when she really, really needs it so that she's not in severe pain. Because again, her nerves don't realize that her legs aren't there, and her spinal column is also a little, it's just janky. It's just janky. That's just all there is to it. Janky. So remember, when we go through our nursing process with any patients receiving narcotic therapy, it's the exact same thing. Before we do anything, these patients, health history, past medical history, past surgical history. Are you pregnant? Any chance you could be pregnant? Are you breastfeeding? Smoking. Do you smoke? Do you use caffeine? Do you use drugs, recreational or otherwise? What's the baseline vital signs? If we can get labs, fantastic. And then we're going to assess and reassess. Assess and reassess. It's like, okay, I'm looking at you now. Do you still look the same? Okay. We want to make sure, especially when we're first giving those narcotics, we're going to check on about every 15 to 30 minutes for about the first hour, just to make sure that we're not having any kind of a funky reaction. And again, is there any kind of adverse reactions? The world's worst thing is to cause a new problem. You know, you give a patient, they're in horrible pain, you give them morphine, and then they start puking. That is not what I wanted to happen, okay? I wanted to give them the morphine so they would stop hurting, and it would make a huge difference. So if you have some of those adverse reacts, just let your primary care providers know and say, hey, this is what's going on. Can we have this now? And they'll usually give you something. Sometimes the doctors will be like, you know what? I'm gonna stop you before you even ask. We're gonna give, for instance, we'll give morphine and Zofran, not at the same time, but within the same, I'll give my Zofran first, so that way they're not puking. I wait 5 minutes, and then I give them morphine, since I know that the morphine can cause a little nausea. And again, am I getting the therapeutic effect that I want? This can be really hard, because I can ask a patient, hey, how's your pain? And they're like, oh yeah, my pain's great. Or they're like, no, my pain is horrible, and they're looking like you and I do right now. And I'm like, okay, what do I document here? So again, I document vital signs, I document what the patient says, and then I'll say, no pain indicators, no facial grimacing, patient sitting up in bed, feet crossed, no apparent distress. Okay, and then always address safety concerns with narcotics. Remember, do not drink, do not drive, and do not operate heavy machinery while taking this medication. It can lead to an unsafe drop in blood pressure. Provided a couple little extra resources here for you in regards to some of those cardiac medications that we spoke about in part 1, and about how they actually provide some pain control. Again, I feel like if you're going to see these, you're going to see these in some like primary, not in pain specialty areas, not so much in primary care. But if you see these patients coming on this medication, you need to ask. So tell me, I see you have clonidine here. Why do you take the medicine? If they say blood pressure, you write blood pressure. But if they say for pain control, you write pain control. All right, guys, that is all I have for you about narcotics and other fun things. If you have any questions, please send me an email.